Hi, everyone, and welcome to my research proposal. It is titled Behavior Interventions for Inappropriate Sexual Behavior in Children. So the initial interest for my research proposal came from a pilot study that was conducted by myself and colleagues at Great Leaps Learning Center in Prattville, Alabama. And this was a case study that examined ABA-based interventions for a 3-year-old who engaged in masturbation over 200 times a day. So clearly this was a problem behavior that was impacting the quality of life of the parents and the child. And our study examined the procedures that I'm going to talk about later today, and they effectively eliminated her masturbation behavior in home and clinical settings. After the study was concluded, many families with children on the spectrum expressed difficulty in teaching appropriate sexual behavior and treating inappropriate sexual expression. So I'm very interested in expanding this study and to make it into a true experimental research design. So the experiment will evaluate 2 behavior treatment packages to treat high-frequency masturbation. And the 2 treatment packages are non-contingent reinforcement of automatic stimulation, and then NCRS with the addition of an overcorrective functional movement training. So a reinforcement procedure and then a reinforcement and punishment procedure combined. And the research question is if OFM and NCRS procedures, or NCRS alone, are more effective in reducing high rates of masturbation for children ages 3 through 6 diagnosed with ASD. So why is this research important? Well, it's really common for children ages 3 through 6 to develop sexual behaviors, especially masturbation. Children typically learn the appropriate sexual boundaries from social cues, such as adults telling them no, or telling them to go in their room, or negative peer reactions. And children on the spectrum frequently require direct instruction to learn socially appropriate behaviors. And parents and teachers and therapists often have a lot of discomfort and are ill-equipped to provide these direct lessons to children on the spectrum. Without proper behavior interventions, children with autism are at risk for detrimental social repercussions, such as injury, infection, legal ramifications, limited access to the community, and academics. And this actually happened to the young girl in our case study. She had multiple infections, and when she went to daycare, they put her in a room by herself without peers or a lot of supervision because the behavior was so detrimental. This is a picture of me with a client at the clinic. So my literature review consisted of about 10 sources, but my main source was a meta-analysis conducted by Cicero in 2018. And this meta-analysis divided the behavior interventions for inappropriate sexual behavior for individuals with developmental disabilities into 3 categories. So 1 are standard procedures in the field of ABA. 1 is a reinforcement procedure to increase appropriate sexual behavior, and the others are punishment procedures to decrease inappropriate sexual behavior. So standard procedures are used so often in the field of ABA, and they were also used prior to the case study, and they were ineffective. But they are differential reinforcement of other behaviors and the other ones that you see here. And Helms highlights the need to do a functional analysis for inappropriate sexual behavior and determine what the function is. So often masturbation is a function of automatic stimulation, which means that children do it just because it feels good and they don't need social mediators to have that behavior occur. So it's difficult to find competing reinforcers. So this definitely makes the effectiveness of the treatment limited. The next camp of procedures are reinforcement to increase appropriate sexual behavior. And researchers began to acknowledge that it's unethical to completely eliminate sex repertoires from a person's lifespan. It's just a normal part of growing up. So they developed curriculum that helps to shape and form appropriate sexual behaviors. And these include going to your room, knowing when other people are around, when you can and can't do it, and specific techniques to allow them to completely reach orgasm in all honesty, so then they don't have to do it all of the time. Obviously, this can be controversial and highly variable due to the client's imitation and repertoire and verbal capabilities, their age, and their disability level. So there's a lot of variability in the application of these procedures. The last one is the bulk of the literature, and it's punishment to decrease inappropriate sexual behavior. Most of the research is when a researcher would deliver an aversive stimulus contingent on inappropriate sexual behavior in public. And in the 1960s and 1970s, this was delivery of an electric shock or lemon juice to children and sometimes adults who would engage in masturbation publicly. Obviously, this doesn't comply with current ethical codes, which are reinforcement procedures should occur before punishment, and that punishment must be coupled with reinforcement. So there was one study that was conducted in 1977 that used an overcorrective functional movement procedure, and this is the one that we will use for the research proposal. And this is when a therapist would guide a child through exercises, arm exercises, such as putting their arms above their head, in front of them, to the side, and in a hugging motion for about 1 minute, contingent on them masturbating. And it effectively eliminated the masturbation in a classroom setting for an 8-year-old, and it did not induce side effects such as aggression. So it was used as the most ethical punishment procedure to be implemented in the experimental design. So as I said, we'll be studying NCRAS alone and then NCRAS in addition to OFM. Again, this goes with current ethical guidelines that try to, and we're going to try to evaluate if reinforcement alone is effective in reducing masturbation or reinforcement and punishment is necessary. And after previous literature review and the case study, the research hypothesis is that NCRAS and OFM will significantly reduce masturbation rates in children with ASD compared to NCRAS alone. So the sampling technique is convenient sampling. Disability services are so far and in between in Alabama, and so we just want people who can participate and actually come to the clinic location in Prattville. Participants must be diagnosed with ASD between ages 3 and 6 and engage in high-frequency masturbation. So here we outlined the operational definition of masturbation, and this is any instance of hands on genitals above or below the clothing, and any instance of placing or rubbing genitals on objects or people. And this definition came from the original case study and is a typical topography of childhood masturbation. The operational definition of our measurement instrument is a direct observation by the BCBA. And a BCBA will directly observe one session prior to treatment intervention and after treatment intervention, so a pre and a post test. And they will track the frequency of masturbation and convert the number of instances per 1 hour session. So the independent variable are the treatment protocols as outlined here, and the dependent variable is rate of masturbation. So now we're going to talk about instrument validity and reliability. So the instrument we're using is direct observation done by the BCBA, and a threat to the reliability is inconsistent observer performance. This is very common within the field of ABA, and this occurs when a masturbation frequency is inconsistently tracked by the BCBA or one observer. So in order to control for this threat, we conducted inter-observer agreement data, and this is when a second observer will also track the frequency and the two professionals cannot interact. And then a level of agreement will be calculated post data collection, and this score will validate the reliability of the direct observation instrument. When we look at the validity of direct observation, one threat is construct underrepresentation, and I applied this to the behavioral definition of masturbation, and this occurs when the assessment tool is too narrow or fails to include dimensions of the construct. So if the behavior definition does not truly encapsulate what masturbation looks like in the participants, the BCBA might not be able to accurately correct masturbation data. In order to control for this, we did an evidence based on test content in which we would consult experts about masturbation topography in order to write a correct definition. In addition, we would observe participants prior to treatment to ensure definition is correct for every client. So the experimental process that we use is a true experimental design called randomized match pairs, pre-test and post-test control group design. So it's ideal that we would have 10 participants, and then we would do randomized matching. So we would match them on relevant characteristics and then randomly assign them to treatment groups. All treatment procedures would be implemented by an RBT in a 1 hour session. RBTs would be trained on both procedures and have high treatment fidelity. And this session would include free play and behavior intervention only. That's why it was only 1 hour. And it would be conducted in an 8x10 room behind observation glass, so the BCBAs and IOA data collector are not in the room and create observer reactivity. Prior to treatment, the BCBA will conduct the pre-test. Therapy will be given for 2 weeks, and then the BCBA would conduct the post-test. So when we look at the internal and external validity of the experiment, there are a few threats. One threat to internal validity is selection. And this is when there are key differences between the groups prior to the experiment. In order to control for this, we did a randomized matching procedure in which we matched participants based on masturbation topography and client ability level, and this would create reasonably statistically equivalent groups. A threat to external validity is experimental effects, and this occurs when the experimenter provides cues to the subjects that might influence their behavior. In order to control for this, we used a variety of RPTs who were all trained in the procedures, and this would hopefully wash out any RPT characteristics that might potentially influence the masturbation rate, such as personality or voice, something like that. Two threats to internal and external validity that we cannot control for were setting treatment interaction and non-probability sampling technique. Setting treatment interaction is when the environment is artificial, and this may limit the generalizability of the results. And obviously, this was conducted in a highly controlled setting without parents and peers and limited amount of toys. And again, the sampling technique was convenient sampling, so this limits the generalizability of all children in the study. The proposed statistic methods we use for descriptive statistics, we use mean and standard deviation. Mean is to calculate the average rate of masturbation between experimental groups, and standard deviation calculates the variance of the data around the mean. And then for inferential statistics, we did a t-test for independent samples, which tests the statistical difference between the means of the two separate groups. And this would allow us to accept or reject the null hypothesis that you see above and determine if the treatments were statistically different or there was no statistical difference between the groups. And neither of these statistical methods were ex post facto because the independent variable was controlled. Thank you for listening to my study, and let me know if you have any questions.